I tell you one thing. As I mentioned in my talk, that whenever you see a ring-enhancing lesion in basal ganglion, that's the most common site for toxo, number one. Number two, when you look at the enhancement pattern of tuberculoma and toxoplasmosis is very ill-defined ring enhancement. Tuberculoma has got a very thick ring enhancement, and that's something which we see consistently in a lot of cases. So that's one of the very important features. And third thing, we see a disproportionate edema to the size of the lesion. The lesion is 1.1 centimeter, 8 millimeter size, but edema is almost extending a lot of mass effect, which you see more often in toxo than tuberculoma.
Thank you. Thanks. Very.
Can I just say something? I forgot to mention it during my presentation. There's if you enter your app, if you could do that, please, and there is on quiz, there is a form that you can fill in, you know, either as a mentor or a mentee. We've put that on your app. It should be there, and that will, you know, that will tell us whether there is stomach for people to, you know, be either mentors or mentees. And then only we will be able to take the program further, okay? So if you check your phones, in the ASICON app, there's a form, and if you could fill that for us, that would be appreciated. Thanks a lot.
Dr. Wilkins, I have a question to you. You talked about the newer drugs like TAF. Now the whole problem is, including India and other developing world, to change over from TDF to TAF, the cost factor, number one. Number two, as a first-line therapy now, you want to have an integrase inhibitor. Again, the cost is an issue. And if you have an integrase inhibitor being used, if it's not dolutegravir, the number of pills burden again. And I thought, well, the newer drugs are welcome. We have quite a few patients in India who are on AZT, 3TC, nevirapine, AZT, 3TC, efavirenz, doing very well for 10 years, 12 years. And to me, it looks like I would be reluctant to switch over to it. There are no side effects at all seen cumulatively. I just thought your comments, please, don't get me wrong. Yep. I would not be ever tempted to start. Yep. See, I would like to use integrase inhibitor in my country as a second line, third line therapy. Yep. You say such as dolutegravir, which is available with me today.
Okay, I'll be very brief. Everybody has patients who are very happy on their combination. They've been on it for 10 years, and I would never dissuade them from carrying on, as long as they didn't have any toxicity. And so I'd be very happy if they wanted to carry on their nevirapine and combivir, if they got no lipoatrophy, nothing at all to make them switch. And some patients never get lipoatrophy. So I'm all in favor of just not rocking the boat, as we say. With regard to TAF, I expect it's going to be easier for you to prescribe it and cheaper for you to prescribe it than it would be for us. I mean, it's going to be impossible for us. We're going to be restricted to patients who have absolute strict criteria fulfilled for renal and bone. I would imagine, I mean, if I had choice, there was no cost implication, I would switch everybody over because it's a safer drug. I'm not saying that Truvada isn't a fantastic drug, it is, but TAF is safer. And so TAF, FDC, and Adefsi, which is rilpivirine and TAF, there's not going to be any efavirenz in TAF, but you can split that up. There may be over here, I don't know. But I would go over, but we will have to restrict use. And so with advice to you, I would have thought that if you're under the same situation as us, you would use TAF in patients who have established renal or bone toxicity, or they have renal problems, you know, a low GFR, if not toxicity, but it's an option for using there. And obviously, it's an alternative where you would normally use tenofovir, so, you know, whether HLA B57 positive and things like that, but they've got a complication where you can't use it. But I'd be putting everybody on it if I could.
No, my only the message here was that we don't want to run short of menu because we have a limited drugs, almost most of the drugs available here, and the recommendation keep on changing. It's all right for me. I attend various conferences and I don't get influenced unnecessarily. But people will just try to get the people who are newer, as Dr. Jyoti there said, the new method, they want to get tempted to the newer guideline. And I personally believe that the drug that is working,
I agree with you.
Even tenofovir itself, if it is working well, don't disturb it.
I wouldn't disturb it, but I think when it comes to Truvada to TAF, FDC, it is not like moving from one non-nucleoside to another non-nucleoside. This is basically the same drug. It's the same drug in the cell. It just means you don't have the same level of tenofovir in the plasma, and so you're taking away the toxicity. But it basically is the same drug.
Thank you.
I had a thought for the mentor survey. So if I understand correctly, and I looked at the survey, it's mostly for clinical purposes, and I was wondering if research is incorporated into it, does it need special considerations both from the mentee and the mentor?
I left that for the training committee to decide, because I felt that the international faculty, if they were involved, they'd bring something additional to the whole process. That was my impression. But obviously that's for the ASICON training committee to decide whether they want us to be part of that. I'd love to be a part of it, but it's just something that, I just,
Yeah, it doesn't have to be international, but even if it's national,
yes,
research considerations can be right.
Yeah, because that will bring additional.
Any further question? Any further question? Then we're running all short of time. Everybody's hungry. Let's conclude with thanks to all the speakers and my colleagues here. Thank you.
Before we conclude, can I just have a show of hands for people who feel that the scheme is worth trying out? Because obviously, okay, thank you.
I'd request the co-chairs to felicitate Dr. Mehta.